Good afternoon. It's a pleasure for me to be here today at the 12th Annual Women's and Heart Vascular Symposium. I'd like to thank Dr. Stephanie Coulter for the invitation to be here, and again, take a moment just to congratulate her on what she's done to promote awareness in cardiovascular disease in women and to implement activities in the community and throughout the state of Texas, an educational symposium. So congratulations to Dr. Coulter. So the title of my presentation today is Cardiometabolic Health, Actionable Preventive Strategies and New Care Models. And what I'd like to do over the next 15 minutes is describe recent epidemiologic trends in cardiometabolic diseases, identify actionable preventive targets or strategies, and discuss potential care delivery strategies that we can use to target prevention. So we are keenly aware that the prevalence of type 2 diabetes continues to increase throughout the U.S. These are data from the CDC demonstrating the prevalence of total diabetes in the United States, which is estimated to be approximately a little over 12%. We can see that this has slowly increased since 2001, and encouraging, some data has suggested it's plateaued, but we can see that there had been this gradual trend. Furthermore, if we look down to the orange line, we realize that approximately 3% of individuals have undiagnosed diabetes, which remains an important public health issue because these individuals are not being treated and are not being treated with preventive strategies. So when I talk about the epidemiology of diabetes, I want to just focus on a couple of issues that relate to the strategies that we're going to implement to reduce the burden of cardiovascular disease and to ensure that these strategies are equitable. So I'm going to just spend a few moments talking about the disproportionate burden that certain populations share of type 2 diabetes. The first is that there are significant disparities in the prevalence of diabetes based on race and ethnicity. On this slide from data from the CDC, we can see on the right that prevalence of diabetes in people who are non-Hispanic white is around 7.4%. And if we look over to the left, we can see that those individuals who are American Indian or Alaska Native have nearly twice the prevalence of type 2 diabetes at 14.5%. And when we look at Hispanics and non-Hispanic Blacks, we can see that prevalence is significantly higher at around 12%. And we know that race and ethnicity really is a marker for some of the social determinants of health. And so if we look further at some of the social determinants of health, we see that there are marked disparities. This slide demonstrates the prevalence of 2 diabetes based on education level. And again, if we look at the right-hand side, we can see that those individuals who have more than high school education have a prevalence of approximately 7%. If we then move toward the left of the slide and look at those individuals who have less than high school education, those individuals who may have less health literacy, we can see that their prevalence is almost twofold higher at 13%. And it's important to keep this in mind as we develop strategies to lower the burden of diabetes. Furthermore, this slide demonstrates the prevalence of diabetes based on household income. And what's shown on the x-axis is the federal poverty level. At the far right is greater than 500% of the federal poverty level for a household income. And on the left is less than 100%. And if we start on the right and we look at total prevalence in blue, we can see that those individuals who are at 5 times the federal poverty level, that their prevalence is around 5.6%, with some difference between men and women. Now, if we move over to the right, we can see that there's marked disparities, that indeed the total percentage is almost threefold higher at 14%, and slightly higher in women than in men for the prevalence of diabetes based on income level at the household. And again, when we think about strategies, the healthcare system delivering strategies to prevent the burden of diabetes or the health and improve health outcomes, I think we have to remember that these are the populations that may be most vulnerable and that we have to ensure that we provide equitable care. Now, we've known for a significant time, and I'm sure that people listening to this conference are quite aware that cardiovascular disease is the leading cause of death in individuals with type 2 diabetes. And the diabetes increases the risk for essentially every manifestation of cardiovascular disease, including coronary artery disease, stroke, and heart failure and peripheral arterial disease. This slide demonstrates temporal trends in some of these diabetic complications. Here we see acute myocardial infarction in orange, stroke in a light gray color, lower extremity amputation, PAD, and end-stage kidney disease. And what these temporal slides show us is that we have had significant improvement. So we should take a moment and congratulate ourselves in how we treat people who have type 2 diabetes. And we can see from 1995 to 2010, in these people who are older, that we had significant improvement in these complications. But we can see that around 2010, these improvements really seem to plateau. And what's more sobering, or really a call to action, is when we look at the individuals who are middle-aged, those individuals who are 45 to 64, and those who are younger, those who are 18 to 44, we can see that indeed we made progress. Then that progress slowed, and over recent years, there's been a slight uptick in these curves for both middle-aged adults as well as younger adults, which really represent a call to action to implement preventive strategies. So let's turn now to what are the actionable targets in patients who have type 2 diabetes. And these are data from the American Diabetes Association and the European Association for the Treatment of Diabetes. And the guidelines really emphasize a holistic, person-centered approach to type 2 diabetes, keeping the patient at the center and remembering the goals of care to prevent complications and optimize quality of life. Now, when we look at the tenets, or what are the actionable items, we see that they really break it down to 4. Medications for glycemic management, here in the yellow, a strategy looking at targeting weight management, cardiovascular risk management, and then finally cardiorenal protection, and choosing glucose medications such as SGLT2 inhibitors and GLP-1 receptor agonists that have been shown to reduce cardiovascular disease in people with diabetes. And these actionable targets all occur within the principles of care. We use multifaceted interventions that include language, preference, shared decision makings, a variety of different principles that are involved in our care delivery. So let me look at each one of these individually over the next few minutes. The first the actionable item focuses on medications for glycemic management. And the guidelines really state to choose an approach that provides the efficacy to achieve the goal that you're trying to achieve. So if someone is having a very high hemoglobin A1C, we will try to use agents that have more significant effects on A1C control, including insulin. In general, metformin is considered the first step in therapy, and then other medications are combined to achieve the glucose control that is needed. The recommended target for A1C is less than 7% for most adults, but individualization of less than 6.5% can be used in those people who have newly diagnosed diabetes or who have less complications. But we should reach for less stringent goals in patients who have shorter life expectancy, or who have extensive comorbidities or may be having issues with hypoglycemia. If we then turn to the target of weight management, the guidelines highlight the need to individualize our strategies here, to set individualized weight management goals with the notion or the awareness that even small amounts of weight loss can lead to substantial improvements in A1C and cardiovascular risk factors. This strategy should include general lifestyle advice regarding medical nutrition, therapy, eating patterns, and stressing the importance of physical activity. Furthermore, if we have access to intensive evidence-based structural weight management programs, these should be utilized. Finally, we should consider other interventions in patients who continue to have issues with obesity, including medications for weight loss, such as the GLP-1 receptor agonists, or more recently, the mixed GLP-1 GIP agonists, such as tirzepatide. And then finally, to consider metabolic surgery. I know personally that I have sometimes been a little bit delayed in referring patients to metabolic surgery, but diabetes remission can occur for several years in many patients, and observational studies suggest that we may improve cardiovascular. I'd like to now turn to cardiovascular risk factor management. And this includes ensuring strategies are in place to deal and optimize multiple cardiovascular risk factors, including assessing risk factors at each visit, performing cardiac testing when people have symptoms, a real focus on blood pressure lowering, reminding us that the blood pressure goal is less than 130/80 in most individuals with diabetes, that ACEs and ARBs should be used in patients who have kidney disease and or coronary disease, but more than often we need multiple therapies to achieve goal. Lipid lowering, the crucial nature of lipid lowering therapy, including moderate to high dose statins in people who have established cardiovascular disease or multiple risk factors, in reaching for additional agents such as ezetimibe or PCSK9 to achieve aggressive goals in patients who have established disease, antithrombotic therapies such as aspirin, and focusing on smoking cessation. The final pillar in looking at this holistic approach set forth here is really to begin to choose medicines that have cardiorenal protection. And these are diabetic medications. And remember, this is separate than medications used to treat glycemia, right? The decision to use one of these medicines is not based on A1C or not based on background metformin use, but really based on cardiovascular risk factors or disease that's present in patients. And this is what the guidelines recommend, that in patients who have atherosclerotic cardiovascular disease or indicators of high risk, that we should be using a GLP-1 receptor agonist with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit. If the A1C remains above target, we can then reach for the other or use these medicines in combination. In patients with heart failure or even pre-heart failure who have high BNP or biomarker abnormalities, that we should be using an SGLT2 inhibitor that's had proven heart failure benefit in this population, which is subsequently been extended to all patients with heart failure. And then finally, in patients who have chronic kidney disease, who are on maximally tolerated doses of ACE or ARB, that we should be reaching for an SGLT2 inhibitor with primary evidence of reducing CKD progression. If the renal function is too advanced, then we can use a GLP-1 receptor agonist. Certain GLP-1 receptor agonists can be used in patients with advanced kidney disease. So we, again, bring it and center these goals around the patients. So how are we doing? So let's turn to what are we going to do to close gaps and how can we implement therapy? Well, I would say that we're doing okay, trying to be optimistic, but that we have opportunities for improvement. Data regarding 3 risk factors, hemoglobin A1C, blood pressure control, and lipid control in the NHANES data between 1999 and 2018, over 20 years. And what we can see is that for hemoglobin A1C and looking at a value less than 7%, that we had improvements early on, but that these improvements have plateaued and only 50% of people achieve target. Similar, when we look at blood pressure control using 130/80, we can see that in fact, we've had a small decrease and less than 50% of individuals reach that target. Lipid control improvements in the first part of those 20 years, but then a plateau. And most importantly, when we look at all 3 risk factors, we can see that only 22% of US have all these 3 risk factors controlled. Similar, when we look at patients with atherosclerotic disease, so we move that spectrum more towards people who have disease and say, well, how are we doing on lipid-lowering therapy, glucose-lowering therapy, or blood pressure-lowering therapy in those higher-risk individuals? We can see that only 57% of people are on a statin, and of these, only 27% are on high dose. Looking at GLP-1 receptor agonists or SGLT2 inhibitor use in 2018, when this study was done, only about 3 to 4% of individuals were treated with those medications. So we have a long way to move. Blood pressure medicines, about half were ARB. And when we look at all 3 therapies, we can see that only 5% or so were receiving all 3. So how can we do better? I think we have to move from our reduced siloed care model, right, or reduced siloed care. And remember that multimorbidity is a norm, that these cardiometabolic drugs and the effects of SGLT2 inhibitors, not only on glucose control, but on cardiovascular disease, blur the lines between traditional specialties. And we have to focus on chronic care models where our delivery system is moving from a reactive system to more of a proactive care delivery system, where planned visits are coordinated very through a team-based approach, not through an individual, but through a team, nutrition, pharmacists, dietary interventions, social workers. That we promote diabetes self-management support through new platforms, through web-based platforms, through mobile apps. That we improve our ability to decision support, looking at evidence-based and point of care reminders, both to the provider as well as the patient. That we really begin to use clinical information systems and registries to provide real-time feedback regarding how we're taking care of patients, how are we doing, so a self-learning healthcare system. Dr. Coulter has done a good job, and we should follow that example of engaging community resources and policies, identifying people who are doing this work, nutritionists, exercise, YMCA, and really improving our health system. And so there's been this notion of a cardiometabolic clinic where we can bring all these facets in, but centered around the individual. So in conclusion, the health burden of diabetes continues to increase, and certain populations share a disproportionate burden. There are multiple actionable targets, including SGLT2 inhibitors, GLP-1 receptor agonists, and other cardiovascular risk factors that we should focus on. But these care models that focus on these actionable targets should focus on a holistic approach to cardiometabolic health and include the integration of multiple healthcare disciplines. So again, thank you for the opportunity to be here. And I, again, thank the organizers and Dr. Coulter for the opportunity.